Welcome to Modern Medicine with Doc Moylan. My name is Dr. David Moylan. I'm the medical director of the Simon Kramer Cancer Institute in New Philadelphia, where we serve both Schuylkill and Carbon counties. What we usually do on Modern Medicine is to bring in local and regional experts in the treatment of cancer, and this has been very interesting to our viewers. We're going to have a slight departure from this approach in that we're going to screen a video, a movie called Shine a Light. Now, what is that about? Well, we at the Kramer Institute are on the cutting edge of many innovative approaches to cancer management from the radiation standpoint. For instance, we have microwave hyperthermia, which is excellent in augmenting the effect of radiation on superficial tumors like cancer of the breast, lymph nodes in the neck, malignant melanoma in the skin. And we've been doing that for the last 25 years. Also, 25 years ago, we initiated a program at the Kramer called grid therapy. What is grid therapy? Well, that's what this movie is going to explain to our viewers. It's basically a special filter on the radiation that allows us to give what I would call priming doses of radiation to tumors that are on the larger size. Once a tumor gets to a certain dimension, the blood vessels in the tumor are abnormal, and there is improper delivery of oxygen to the cancer cells. Without oxygen, cells become resistant to the effects of radiation, the anti-tumor effects. So this grid therapy allows us to overcome that resistance. We apply it to about 10% or so of our patients with larger tumors. And it was invented by one of my professors at Jefferson Medical College. His name is Dr. Mohammed Mohyuddin, and he invented the grid while he was at Jefferson. We used it quite a bit. And at the Kramer, which opened in 1998, we acquired a prototype of the grid, and Dr. Mohyuddin's team, and he was at that time at the University of Kentucky, calibrated the grid for us. And we have two sizes that we'll show you during the presentation. One is 5 millimeter grid, and the other is 9 millimeter grid, depending on the tumor size. But in this film called Shine a Light, we're going to hear from Dr. Mohyuddin and actually his son, Majid Mohyuddin, who is a radiation oncologist that practices in Chicago, Illinois. So without further ado, I would like to introduce you to this wonderful, innovative device for managing bulky cancers.
You know, I did some research in the labs. I did an externship in radiation oncology as a medical student. And when I was there, I was exposed to this kid who was like a sophomore in high school, a young girl. And she had ovarian cancer, and she was a patient of my dad. And her entire abdomen and pelvis was filled with tumor. And she looked like she was 7 months pregnant. And there was nothing anyone can do. She was refractory to all chemotherapies. She basically didn't have much to live, and she sort of expressed to my dad she just wanted to make it to her prom. So my dad said, well, I have this treatment called a grid, and let's try this. And he did it, and it regressed. And she was able to wear the dress and go to prom. And so this was somebody who was near my age. I was just in medical school, and this was like magic.
Some stories are worth telling. Stories of human lives, overlapping, connecting. Stories of history, of progress, of discovery. Stories of family, the knowledge and the ways of the heart passed down through generations. And stories of healing. Stories where even in the darkest of hours, the light of hope can spark and sometimes shine. This is the story of all these things. This is the story of the grid.
I think the first 4 or 5 Nobel Prizes in physics were all given to discoveries in radiation of some kind. And as early as 1902, they started using it for treatment. But they started running into some issues. But how do you get dose in deep-seated tumors? They were having a lot of excessive skin breakdown. And so it was a learning curve at that time. There was a guy named Kohler in Germany who struck upon a plan of using something, what he called a perforated sieve. This is like 1902. And so he called it a perforated sieve. And basically what it was a piece of sort of lead that you placed on the skin that blocked some of the skin area and let open some of the open areas, and the radiation could be given that way.
In the early days of radiation therapy, treatment beams were of low energy and their biological impact was at relatively shallow tissue depths. In harm's way was the skin. In fact, radiation skin burns were a limiting factor on how much dose could be given. Why did they suspect the perforated sieve might work? Accidentally or deliberately?
I think they were just trying different things, and what they discovered is initially is the skin toxicity was just so high. So how do you save the skin and let some dose in? So they thought, well, let's kind of open up half of it to the radiation and close half of it, and maybe it would have a chance to repair. And so that's what they started doing. The actual word grid kind of came around 1933. There was another physician in the US called Liberson who wrote a paper that's in the radiology and sort of described the same sort of thing. It was a lead block that was kind of covered with rubber. It was put on the skin itself, and it was sort of open and closed. It was like a 50% open, 50% closed ratio. Not that much toxicity to the skin. You could hit the tumor, and then the skin miraculously would be fine. It would recover.
What I'd like to show our viewers is these 2 prototypes of the grid technology, which was invented by one of my professors at Thomas Jefferson Medical College, Dr. Mohammed Mohuddin. And we developed these in 1998, and they've been available for treating patients here at the Simon Kramer Cancer Institute. Now you might notice that there's two different size holes. This is a 5 millimeter grid that we use for smaller tumors, and this one over here is a 9 millimeter grid for some very large tumors. And our experience here at the Simon Kramer Cancer Institute duplicates what you'll see on the video with Dr. Mohyuddin and his son, who's also a radiation oncologist. I would say that 20% of our patients can benefit from grid therapy. And again, we're using it several times per week here at Simon Kramer.
The invention of the linear accelerator revolutionized radiation therapy, as these machines could generate beams of much higher energy than their predecessors. High energy beams were able to penetrate deeper inside the body, but there was another surprising benefit: they would better spare the skin via a phenomenon called the buildup effect. After more than a century of modernization, driven primarily by technology, we turn our eyes back to an old horizon, that of radiobiology, where the dawn of discovery is rising yet again.
You know, radiation oncology is in my blood. I'm actually third generation radiation oncologist, which sounds kind of crazy. My father's a radiation oncologist. My father's older brother was a radiation oncologist. So this is going back to the 30s or so. In some sense, I'm lucky. I'm a third generation radiation oncologist, so there's some institutional memory. And so when my father was at the Royal Marsden, he had come across the grid from his mentors.
Spatial fractionation is not new. It was there in the very early days of radiation oncology, but how it was applied with the development of newer technologies, etc., I was able to mold it in a slightly different direction, learning from the past. My experience at the Royal Marsden Hospital in London was quite unique, that the physicians dealing with the cancer patients were trying to solve very large problems with their clinical acumen, and they were very innovative in coming up with ideas on how to solve issues with regard to the patients. I was also fortunate in training under some giants of radiation oncology at that time. So David Smithers and Manuel Lederman and Julian Bloom, etc., who were considered really at the pinnacle of the profession. And many of the early radiation oncologists who established themselves in the United States used to come there at the Royal Marsden for their training. And I was really in the middle of this.
Those who've been a part of scientific progress know that it rarely happens alone. It's usually fueled by interactions with friends, colleagues, mentors. And this was certainly the case in those early years, many decades ago, at the Royal Marsden Hospital. Though this was before Majid Muhaddin was even born, the stories were passed down from father to son.
There was a guy named Manuel Lederman who was there, who was very famous for head and neck cancer. And on occasion, he would use this grid, even though they had sort of stronger, they had cobalt machines at that time. But every once in a while, he'd get this really large head and neck cancer, and he would say, well, we'll do ortho voltage, and we'll do 3 gray or 4 gray times 3 fractions, but put the grid on it, whatever old grid they had, and treat it. And it was a palliative dose at the time, but my dad was very surprised at the effect that would have, because when you did it open, it wouldn't work that well, but when you did it with the grid and it was ortho voltage, it worked surprisingly well. And so it stuck in his mind. And when he left the Royal Marsden, he went to Philadelphia. He was at Thomas Jefferson. Simon Kramer was the chairman there. He was also from the Royal Marsden originally, and that's why he went there. And when he was there, they sort of gave him carte blanche to sort of explore all these different ideas and thoughts. So when he was at Jefferson, he came across these sort of tumors, these very, very large tumors. At that time, they did have linear accelerators. At that time, also, intraoperative radiation had become very big. The idea of giving a single dose en face, usually electrons, in the operating room of 12 gray, 15 gray, and he sort of put two and two together. He said, what if I could take this technology of intraoperative radiation and use it with photons, kind of marry it with a linear accelerator instead of the orthovoltage machine, and then kind of see if there's a bigger response like I had seen with this grid thing before. And so he sort of tried it. And so that's where that was born, in the 80s, where he started using the grid with the linear accelerator, getting greater depth dose penetration. So he married a newer technology with a very old one that everyone had forgotten about, treating tumors that no one really could do, and doing it with a big dose up front, which was something that was new. He was sort of the first person to do it like that, because he kind of married a couple of concepts together. When I became an attending, I went from there to the University of Maryland. They were familiar with grid because there were a couple of people who had been from Jefferson there. And then I sort of took on that grid program. And then when I started treating, I just saw these phenomenal results. I had a woman when I was in Houston who had a sarcoma of the arm, an elderly woman. I think she was in her 80s. And this was a very large sarcoma of the humerus area, and it was rapidly growing. She was going to be treated with conventional. Well, actually, she saw the surgeon, and the surgeon said she needed an amputation. I mean, it was growing so quickly, and she was elderly, and almost like you would clutch your handbag, she said, heck no, you're not taking my arm. I'm living with my arm or I'm dying, you need to come up with something else. So the conventional sort of treatment is to give preoperative radiation, which is about 50 gray of radiation. And then ideally, if you have some sort of response, then they go for surgery. So she started off with some conventional radiation, but the problem is this tumor, this sarcoma, for whatever reason, was growing as we were doing the treatment. So from the time of simulation to the time of treatment, it was bigger than the field that they had created for it. And there was literally a tongue of tumor that was extending out. So the question was what to do. And so I said, let's try to do this grid treatment. And what we did is we simulated her and we got her in for a treatment of 18 gray, one-time fraction. And what's interesting about this case is, again, we did grid, which again is a partial volume treatment, obviously, because half of the holes are open and half of the area is closed. But this tumor in particular was wrapped around the bone of the humerus. And so what we did is we treated the area that was away from the humerus. So I kind of drew the humerus in the treatment planning system, gave it about a 1 centimeter area of avoidance, and I just treated the large part outside of that. Okay, so I'm treating partial volume of the entire volume. And we gave 18 gray. And what we were supposed to follow that up with is another 50 gray of radiation. That's the conventional standard of care. Well, the surgeon who was involved with this was concerned about doing surgery after such a large dose of 18 gray and absolutely refused to let us go to 50 gray, which is the standard dose. He said, it has to be 50 gray, that's it.
To summarize here, the surgeon set an upper limit of 50 gray in total, including in it the priming grid dose of 18 gray that would normally be given before a full course of 50 gray. In other words, to satisfy the surgeon, Dr. Muhadin had to treat this patient with a much smaller total dose. Conventional wisdom would say, this is simply not enough.
So we ended up only treating 32 gray. And anyone who's treated sarcoma knows that 32 gray is not enough to shrink a sarcoma. This is not a liposarcoma. So you know that that's not enough to treat the tumor.
But lo and behold, despite being restricted to a much lower total dose than normally prescribed, the grid therapy worked. The patient's tumor disappeared.
What was interesting is we had images beforehand, MRI beforehand, and we had MRI after the course of radiation and before surgery. And what happened is the tumor regressed, meaning it was gone. The vast majority of it was gone. Not only was it gone from this area, the area that had not gotten irradiated by the grid wrapped around the humerus had shrunk away from the humerus and now made it a much more easily resectable tumor. So that one sticks out in my mind because really what the surgeon ended up doing was just basically debulking whatever happened to be left, which was very little. The tumor literally sloughed and fell off and really was just closing the flap defect. But the tumor literally disappeared, and I know that the 32 gray was substandard for preoperative treatment. And I know that the grid, even if that had an effect, was causing an effect in areas quite distant. And so she was able to preserve her arm. And that obviously meant a lot to her. I had a patient when I was at the University of Maryland with inflammatory breast cancer. The problem that she was having at that time is she had a huge breast and the nipple had completely eroded and disappeared and was replaced by caseating necrosis. And so she couldn't eat because the smell of her own decaying flesh on her breast was preventing her from tolerating her own body. And that's where she was at. And this patient had been through chemotherapy. When you have a large tumor that's this big and it's pretty much outstripped its blood supply, even if you give chemotherapy, it's not getting to the tumor. The tumor is necrotic. So I gave the grid treatment. I think it was 18 gray, and I followed it with conventional radiation 50 gray. And she never had surgery. But what was nice was about 3 months later, when they did a CT scan, the reading by the radiologist who never saw the patient said, interval mastectomy. That's how they read it.
Now, it's worth a pause to review here. This was a case of an enormous tumor, treated with the grid followed by a conventional course of radiation. The treatment was an astounding success. Not only did the tumor disappear, but the patient didn't even need post-radiation surgery. In fact, an independent radiologist read the post-treatment medical images and assumed surgery had actually been performed. This relatively obscure grid treatment technique had effectively performed a successful surgery, not with a knife, but with light.
Because what had happened is the entire tumor had sloughed off, disappeared, and then the skin and the chest wall had completely healed over. Now, it did require a little bit of wound care, but basically that entire disease had disappeared. These are sort of the cases where you're like, they stick out in your mind, and her quality of life just improved that much. And that was an inflammatory breast cancer, which is a very difficult thing to treat. I had another gentleman that I treated here when I was in Illinois, and this was a patient with melanoma. And this is a patient who presented with a very, very large neck mass. I mean, huge, large neck mass, almost like a second head. The head itself was being forced to be tilted to this direction. And so he was stuck in this sort of position. And we treated, and this was a patient with melanoma, which is considered a radiation-resistant sort of tumor, a very difficult type of tumor. And this is a patient who had been through all the Yervoy, Opdivo, immunotherapy options that is usually given for melanoma. And this had progressed through all of those. So as a last-ditch effort, I gave this grid treatment. And not only did it shrink, but the immunotherapy drugs that were given afterwards that the patient had become refractory to, he now became sensitive to the drugs again. And so the medical oncologist got extremely excited because now it's sort of like we had given another new lease on therapy. And so this completely disappeared with very, very good skin that was intact. He had complete mobility of the head and movement, but then also his other areas of melanoma improved. So it was a local effect, but also ended up having a systemic effect.
So there you have it, a rather simple yet effective technique for managing very advanced cancers. In our experience at Simon Kramer Cancer Institute, where we've used this technique since 1998, we've seen excellent pain relief for patients with these advanced tumors, and also melting away of cancers like you saw in the video. And we've also used it for some advanced lung cancers, and we've been able to convert them to operable cases, and it's just been truly amazing. Here at the Kramer, we have used prototypes of the device, but now, since it's so well established nationally, a company in Florida does manufacture the grid therapy, and it can be purchased by a medical practice. So if you would like to find out more about the grid technique, please contact me at the number on the screen, and I'll be happy to evaluate you or your loved ones to see if the grid technique is right for them.